Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Suzanne Lentzsch, who's professor of medicine and director of the Multiple Myeloma and Amyloid Program. She's also associate editor for our prestigious Journal of Clinical Oncology. She's at Columbia University Irving Medical Center in New York, and we're going to talk about something that she has contributed immensely to the development of in the last few years, and that is novel monoclonal antibodies for the management of amyloidosis. Welcome, Suzanne.
Thank you, Ravi. Thank you so much for having me here, and congratulations on that really important video podcast.
Thank you very much. So the thing is that we have done programs before for people to inform them about amyloidosis and its workup. So for those who want more basic education, we'll direct them to those videos. But we're going to dive into something that is a little more advanced, and that is how do we treat something that like amyloidosis with drugs that can get rid of deposited amyloid. So before we get into that, can you give us a little overview about amyloid fibrils? What do we know about its formation, and which lays the groundwork for some of the treatments that you've been developing to solve this problem?
Yeah, so light chain amyloidosis is a subtype of amyloidosis in general. We know that there are many different proteins, actually over 30 proteins, that are able to form amyloid. Alzheimer's, for instance, is a type of amyloidosis, also TTR amyloidosis, but also what we treat the light chain amyloidosis. But there's an underlying principle, and that means that you have a protein that starts to misfold. The shape is not straight and not how it's supposed to be. The shape is abnormal, and that's why you have little aggregates like a clump in your pudding, So those clumps stick together, and after a so-called lag phase, you have a nucleation phase. That means where you have a growth of those abnormal form proteins. And once you have a seed, for instance, in your heart with those abnormal proteins, more light chains build onto that existing seed, and we have a phase of elongation. That means you have a seed in your heart, new light chains circulating in your blood, and they stick to the already existing seeds in the elongation phase. So it's growing and growing.
So obviously, this is an area of great unmet medical need, amyloidosis, and most of the stuff that we have has been borrowed from multiple myeloma, which has been one of the disease for which we have had sufficient patients for drug companies to invest in new drug development, and all of them are geared towards getting rid of the plasma cells that give rise to the amyloid. But we have had no treatments that get rid of deposited amyloids. So the analogy of the sink being full, but you can shut off the tap, but what's in the sink is going to take a while to get rid of till you have better plumbing to get rid of it. So obviously, this analogy is a little bit too simplistic, but obviously this is something that we've lacked, and this is something that you have been doing so much of in the last few years. So what can you tell us about where this field stands in terms of trying to get rid of deposited amyloid?
Yeah, I think your analogy with the sink is really good. We have excellent anti-plasma cell treatments, Daracibor-D or venetoclax, really to eradicate the plasma cells in the bone marrow. That means we can shut off the faucet, we can stop the flowing water, we can stop the production of the light chains, but we still have the amyloid in the heart and in the kidneys. And unfortunately, those amyloid is not really affected by the anti-plasma cell treatment. So that means the amyloid still causes the heart failure, renal failure, and leads to the, I would say, short overall survival in our most advanced stages in amyloidosis. So what can we do? The idea goes back, I would say, 20, 30 years, to say, if we can develop antibodies that bind to amyloid and attract with the Fc part macrophages, why not inducing an immune response to get rid of the amyloid? And over the last 20 years, 2 monoclonal antibodies in light chain amyloidosis have been developed, which is KIL-101, also known as anselamimab, or NEO-D001, known as betamimab. So the principle is pretty easy. Antibodies were developed binding to the amyloid, And with the Fc part of that antibody, we attract macrophages or neutrophils and induce that the macrophages, neutrophils eat up the amyloid. That means they perform phagocytosis and digest the existing amyloid. So it's a very interesting, I would say, approach to overcome the hidden amyloid and make it available for the immune system to digest. And we have some preliminary data from clinical trials. You mentioned already, Ravi, that's very nice. One of the drugs, 11104 or KIL101 or anselamimab, was tested in a first-in-human clinical trial here at Columbia. I remember 2014 when we first infused, or when we infused the first amyloid patient with that medication, not knowing what will happen if this antibody goes to the heart and induces immune response with inducing phagocytosis by macrophages. Will the patient be okay? What are the side effects? Will it help? So it was a first-in-human early phase 1a/b clinical trial. And it was supposed to show safety of the drug. That means that nobody gets any harm from our monoclonal antibody, KIL101. But what we observed was a surprise that even with very few infusions, patients actually got only 4 infusions. Most of the patients had a very nice response. And what you can see here on the slide is that there is a decrease in the NT-proBNP, which is a marker for heart failure, decreased significantly in most of the patients. So 50% of the patients had a response. That means decrease of the NT-proBNP by more than 30%. That was very encouraging. And we said, okay, NT-proBNP is a heart marker that can be affected by just a salty food, for instance. It can increase if you have fluid overload. So that's why we also looked by echo for the GLS, for the global longitudinal strain. What does it mean, GLS? You can ask the staff that is doing echocardiography in your institution whether they can report GLS. It's a relatively new marker, and it basically shows the contractility of the muscle. That means the lower the GLS is, the better is the contractibility of the muscle. And you can see the blue dots. Those are separate patients with either kappa or lambda AL amyloidosis. And most of the dots, the blue dots, after 12 weeks go down. That means the GLS decreased, the contractility was improved after patients received the medication. So that was very encouraging. And based on this, the product was further developed and is currently or was tested in a phase 3 clinical trial. And in principle, what Calum was doing, they randomized the patients, advanced patients, into a patient group that received standard of care, which was Daracibor-D plus placebo, versus Daracibor-D as a treatment for newly diagnosed amyloid patients, plus KIL1, plus the monoclonal antibody. And we had actually 2 clinical trials, one for patients with 3A and one clinical trial for patients with 3B amyloidosis. The trial has finished accrual, and right now we wait for endpoints because the endpoint is overall survival. So we hope that every patient lives very, very long time. But again, we need to have sufficient events in our control arm to really show that the addition of KIL101 is superior to our standard of care without KIL101, without that anti-amyloid monoclonal antibody. So hopefully we have the result next year, but we cannot promise.
And so what about the other antibody?
Right, yeah. So there was another antibody I mentioned already, NeoD001, also called Betamimab from Prothena. And Prothena did the VITAL trial, which is a phase 3 clinical trial. And similar to the Calum trial, patients were treated, newly diagnosed patients were treated with a standard of care treatment and placebo and randomized to another arm that was standard of care plus the Betamimab. So the endpoint of that clinical trial was difficult because it was hospitalization. And in 2018, a futility analysis showed that there will be no difference between the two arms. That was very disappointing. And we thought, okay, maybe that concept failed. But interestingly, in a subset analysis, it was shown that patients in stage 4 had a significant improved overall survival when they were treated the standard of care plus the anti-amyloid antibody. And you can see that very nicely in the curve that there was an overall survival advantage. And based on this, Procedure was really encouraged to say, hey, what about if we do another clinical trial to confirm those data, but we focus only on the more advanced patients with AL amyloidosis, that means the stage 4 patients. So, and that trial is still ongoing, also accruing. And again, similar to the prior trial, to the VITAL trial, the placebo plus standard of care is compared to the bertamimab plus standard of care. And the endpoint here is overall survival and not hospitalizations, which I think was the wrong endpoint and maybe contributed really to the failure of that clinical trial. So hopefully, more data to come. I don't think that the trial will, that we can expect the data this year, hopefully next year, if there are enough events.
So obviously, we've talked about 2 monoclonal antibodies, and are there some differences in these two? Obviously, they're not going to be direct comparisons, but are there mechanistic differences between the 2 antibodies?
Yeah, so the mechanism of action is the same. You attract with your Fc part of the antibody macrophages, neutrophils, cells that they can induce phagocytosis. The antibody itself is different. It's like you have a BCMA and a CD38 monoclonal antibody because it's raised against a different target. So that might be the difference, and that might decide which antibody binds better, and especially which antibody is able to bind in kappa and in lambda patients. We know that the structures might be different, but that there are also some similarities between the structures of the amyloid and kappa and lambda patients. And we hope that the antibody target similarities of the structures in kappa and lambda to be effective both in 2 types of light chain amyloidosis. Affinity of the antibody to the amyloid might play a role. There are a lot of preclinical data, but I think at the end, the clinic has to decide, is there a winner, or can we use those 2 antibodies complementary? So maybe because they bind to different targets on the amyloid, we can use the NeoD001 and KIL101 antibody together, mix them and have the best response, anti-amyloid response in our patients.
So is there any difference also stated about circulating amyloid versus deposited amyloid? Is that any difference between the 2 antibodies?
Can you repeat the question?
There has been some talk in some circles about the differentiation being partly about getting circulating amyloid light chains versus deposited amyloid light chains.
Yeah, that's an interesting question, because the light chains circulate in the blood and they form fibrils that are still in the circulation, or short kind of, deposits that are still circulating. I'm not aware that really we have good and convincing data that the antibodies are really able to clear those circulating deposits. It would be nice that you somehow, with your antibodies, even block in the circulation and the apposition, but I'm not sure whether we have really convincing data. I haven't seen those data. So I think the main underlying mechanism is still that you induce a phagocytic response by attracting macrophages to the amyloid tissue, which might be also difficult because if you have thick layers of amyloid, you can imagine that you have to give repeat treatments because only the surface is attacked by those antibodies. But again, we have to prove, whether those antibodies are working in our patients.
And is there any difference in the target population being studied in these 2 studies?
Yeah, we hope that originally the KIL101 antibody was raised against patients with kappa amyloidosis. So I mentioned that there are structures in the amyloid that occur in lambda and in kappa patients. And we truly hope that the antibodies will work in kappa and in lambda patients. But again, remember, we do not have that many patients on clinical trials, on the VITAL trials, and on the KLM trial, really to come to a conclusion. Is there any patient population that might especially benefit from the antibodies? I just want to remind everybody that we have 6 different isotypes of lambda amyloidosis, 6 different isotypes of lambda light chains, and 4 different isotypes of kappa light chains. So like we know that certain drugs work better in myeloma with certain mutations, the antibodies might have a preference to work better in kappa 1 isotype or lambda 6 isotype. So I think there is still, if those medications work, there's still a lot of research to do. Is there a certain subtype of amyloid that really benefits most from the antibodies? There was, being a little bit broader, some discussion whether those antibodies would also work in TTR amyloidosis, whether there are common structures shared between light chain and maybe TTR amyloidosis. But I think the data are not sufficient enough or good enough really to conclude this and use those antibodies in, I would say, a broader spectrum of patients with amyloidosis.
And if these trials are positive, when do you expect patients to have access to these? Like, are we how far are we from these being available if the trials are positive?
So again, right now, KLM has completed accrual of patients and is waiting for events. That means enough events of death between the placebo group and the treatment group. I don't know. I hope that we will have, or I don't hope, but you know, it's expected that the data are out 2024. But it really depends, you know, on the number of events. I don't think that we can expect data from the VITAL trial this year. Once we have the data and once they're convincing enough, I think that the FDA is really very interested to approve as soon as possible in a medication with a new mechanism of action in a rare disease and devastating disease, especially in the most advanced stages of patients with AL amyloidosis. So let's hope for next year, but we cannot promise.
Well, I really thank you very much for giving us a glimpse into the work that you've been leading in this area. I hope that both of these are successful trials, and I hope that I can count on you to come and tell us more about these in a year or two and talk about how they're being used. And hopefully I can get you onto another program to talk about amyloidosis and other plasma cell dyscrasias.
Absolutely, my pleasure. And thank you so much for having me.
Thank you.